Right, since we're lagging behind, I would kindly ask you to pick up the pace and allow me to invite Mr. Polyzos, who will be moderating the next table, comprising Mr. Aris Apostolou, President of the National Centralized Health Procurement Authority, Mr. Chalkiavakis, Mr. Messaropoulos, Mr. Kalamakis. Was it Mr. Nikas who was replaced? Right. Perfect. And Mr. Katsarkas. Right, brilliant. Thank you very much. No, thank you, ladies and gentlemen. Good morning. On behalf of the speakers, I should like to thank the President of the AmCham, Mr. Bakatselos, for his invitation, and the other organizers, Mrs. Barbetaki, Mr. Gikas, for the honor and the pleasure they've given us. Now, on the pretext of the invitation of the President, we were invited to talk about policy on the basis of the evaluation, on the basis of healthcare that is value-based. I would be remiss if I didn't call it value-based healthcare. It's a movement in the Western world. Now, personally, I came to know that quite recently in a Harvard Business School collaboration with the Harvard Medical School. And the key thing that they have on top is the strategic policy and strategic management. Policy starts from a top-to-bottom approach and it reaches management that has instructions and guidelines. And then management, on the basis of its strategic or operational plans, shapes and formulates the targets on the basis of the needs it needs to cover for the patients. It says what it will offer and how, and consequently creates the sectors, the departments, and those teams that will give the good results for the patients. It should be noted that even in the mecca of private medicine, Boston, there are partnerships in geographical locations. I mean, Massachusetts General works with other hospitals. Cleveland Clinic does the same. Now, the Karolinska Institute in Stockholm in Europe does the same. So, collaborations per geographical area or location. So the leaderships of health organizations create these integrated units. It's the integrated patient units in English, which shape the good results that are target-based, and these are founded on playbooks that create pathways, protocols, and all these modern tools that lead at the end of the day regarding the assessment to standardized morbidity indicators and, of course, patient-reported outcomes, the PROs, which is given back to the doctors and all healthcare professionals who participate in this cycle of health in order to be evaluated. I will not talk about the gritty reality at all. I just tried to give you some taste of my experience from abroad and what we will be discussing, each on the specific field of excellence, and I will talk about our esteemed speakers, and I will leave Mr. Chalkiavakis for last, which is what I was asked to do, because you'll do the summing up. I will move on with Mr. Dimitris Nikas. He is president of the SEIV, the Association of Health Research and Biotechnology Industry, to ask him for his first comment on the value-based healthcare procurement in relation to the vendors that you are representing now. And I would ask, how does the use of this tool contribute in our country, first of all, in the consolidation of policies and assessments that are result-based, perhaps giving us an example from abroad? Thank you very much, Professor, Mr. Polyzos. This is quite right, what you said about the framework on which value-based healthcare is moving worldwide. I mean, the Harvard Business School is indeed innovative and a pioneer. Professors such as Kaplan and the others have built a framework of how this can actually work, in theory at least, but also in practice. We have seen several successful examples in the United States and Europe alike of such policies. I mean, the treatment assessment on the basis of what they have to offer to patients throughout the duration of the patient's pathway until they receive the treatment, and then during the monitoring, the follow-up in various health systems. If we want to say that this is taking its first steps worldwide and would like to see what the situation is in our country, we would have to realize that we haven't even taken half a step. We're lagging behind. Now, the good thing is that there is a debate that is ongoing. There is some discussion in conferences. There are sessions organized within conferences and congresses to analyze what this whole thing means. And I came to realize that health ministry officials are being trained on this, and there are a lot of them who have seen and then gone to these Harvard seminars. And this value enters into the public sphere, but in essence, the procurement, to come to your actual question, the key way in which all public hospitals make their procurements is value over volume over value, over price rather, volume over price, and value doesn't play a role there, and we should include value, because what it does is it unlocks various problems that are in healthcare. So moving from a model, the only key goal of which is how we can get the best price for the biggest volume, change the paradigm. It's not just the value, it's also the clinical part, it's the financial part, it's the result for the patient. And this means that all participants in this pathway of the patient have a different approach to healthcare. And this is very important. And I believe that innovative technologies and solutions this way can also be acquired more easily by a health system that has finite resources, limited resources, such as the one we have in Greece. I would like to mention an example from abroad. There is a clinic in the Netherlands that is working on obesity, morbid obesity. And they manage to have dietitians, clinicians, and psychologists work together. It was a 10-person team that worked on morbid obesity. To work on this and find great things. And then the reimbursement happened on the basis of value. Tampere in Finland. The patients who suffer from heart failure. So what happens to them? Now, the scheme is the partnership and the collaboration of the hospital with the reimbursement organization. So the least I bring the hospital, the patients in the hospital, at the hospital, and I follow them up remotely, I don't pay a fixed rate, but I pay per month. So I reimburse the way that I choose to manage my patients. Good. This, by extension, influences the cases of partnership and collaboration between hospitals and vendors. I should like to briefly stop here, and I have a couple of more examples to say later on. One for Greece, that actually happened, because we shouldn't say that nothing happened, and a proposal for the future with the EKAPY. Just give us a name. Where? It's the Onassis Thoracic Surgery Center. Now, to draw a conclusion that might help Mr. Messaropoulos. You talked about joint and single quality specifications and value, but I will leave Mr. Messaropoulos and move on to Mr. Evangelos Kalamakis, who is Managing Director of Sofmedica Group. And then, picking up from where we left off with Mr. Nikas, for you to share a similar opinion that is in the very high cost biomedical technology and not alone.
Thank you very much for the invitation. You talked about costly, but this does not necessarily mean that it is expensive. There is a difference between the two. And I'd like to give you some examples. Where can we find value in health? What does value in health mean? What you pay for what you get, basically. And in health, what we get are clinical results, both for the patients as for the hospitals, vis-à-vis certain indirect costs. And the costs that are not obvious are also very important, or the costs that you can avoid. What we are after is to maximize this ratio. And in order to do that, we need to search. We have a graphic example that we show to our customers and to those that the social insurance funds are paying. And you can see that the cost resembles an iceberg, is what you see above water. The point is what lies beneath. And in order to do that, we have adopted a practice for our basic technology, which is robotic surgery, in order to quantify the impact. And I would like to give you 3 examples where we do that. They pertain to doctors, surgeons, and hospitals that are willing to work with us so that we can actually measure certain things. The first is a surgeon in the Biotechnology Institute of Budapest that performs colectomies, and he's in the beginning of his training. He's using the conventional and the robotic method, and as you can see on the screen, we have used the clinical results, like the duration of staying in hospitals, the operation time, the success in sutures, the percentage of readmission, and the percentage of resurgery. These are very specific results, and to the extent that they can actually be associated with costs, like, for example, what is the cost of a daily staying for a public hospital in Budapest? Approximately 500 euros. So this difference of the 2 or even the 5 days that are associated with the open method is translated into a specific amount. Another example that we have as a practice, and these are real-life examples, mind you, a neurologist in Cyprus that specializes in the monitoring of renal-ectomies, nephrectomies. There we have more analytical data about cost, and you can see that we have a lot of information and data about the stay of hospitalization and the operation time. And we also know which is the cost that is avoided. That is the cost pertaining to the openness surgeries. So this on the basis of the operations that this specific doctor has made is in the position to measure the impact that he had on the hospital vis-à-vis the avoidance of cost. And another example, Bulgaria, a surgeon that also performs colectomies, especially with a minimally invasive method. We have a large sample here. You will see that the duration of staying in the hospital and the percentage of change to opened and the need for transfusion are quantified in euros. And the amount is not negligible, actually. So why do we do that? Because, as you said, in the beginning, technologies may come at a cost. So what we do is to adopt the rationale of promoting the investment, in the sense that if you invest in something early on, you will get benefits in the future. And that is why we are trying to explain to hospitals and to all interested parties that it is important for them to prove these benefits. And this can be done only by measuring the results and the outcomes. I would like to stop here, since I gave you some examples, and maybe later I will say some more things. Okay, now the floor to Mr. Messaropoulos, who is the president of the Hellenic DRG Institute. How will DRGs contribute to the assessment of the cost of hospitalizations, and without, of course, reducing the access of patients to what they need? First of all, I would like to thank you for inviting me to Health World. And, of course, I would like to thank Mr. Polyzos. It is always great to be in similar context and having this type of discussions. You know, the first thing I tell in the context of similar discussions is that we develop reimbursement systems, but the point is that these must have some impact on the patients, because the final recipients of services are the patients. So we need to develop systems that will improve the experience of the patients in the system, but also the services provided by the system. And we need to create these conditions for the health professionals so that they can offer better services. And we have a system that has benefits, advances, is the best reimbursement system based on what we have in our hands, of course, and it will benefit the patient. The patient will be hospitalized less. You know, those who do not support the DRG system claim two things: that the patients will die out there on the streets, and the second, that we will keep them in the hospital more so that the hospitals are reimbursed and therefore make more money. None of the two is true. When it comes to the bloody releases from hospitals, as some people call them, and explain myself, when we have a readmission, the patient goes under a DRG, so the hospital is reimbursed on the basis of the previous DRG. So if you have a patient that is not readmitted with any complication, there is no need to release them earlier. But if you release the patient earlier, and this is a practice since we're talking about a dynamic system, then the reimbursement will be to the benefit of the hospital, and the average hospitalization time will be reduced. Something similar stands for the long hospitalizations. There is a minimum limit and a maximum limit beyond which the hospitalization is not beneficial to the hospital, which means that the reimbursement that it will get, it will be less. So what we are trying to do with EKAPY, because we have entered the stage of assessing the data, and as you said, aptly, in the United States, there are monthly reports in the hospitals that you visited at least, and on these, they are based in order to see cost and reimburse these specific hospitals. This is something that has already started in EKAPY. We sent monthly reports to hospital. The reports are analyzed by the managers of the hospitals, returned to the heads of clinics, and if they haven't done that, we ask them to do it so that the heads of the clinics are partners in all of this effort. We need to include the heads of clinics in the effort, otherwise we will fail. And then per clinic, we need to have data so as to know that the reimbursement that the clinics made is to the benefit of the clinics. And that is why we are processing a model of certain benefits in order to get the answer we need. Moreover, these reports are then discussed with the political leadership in order to see how we can improve the indicators. And since we have entered a discussion about the money given to health, I want to say that doesn't necessarily mean that the more money means better services. And we can see that in the hospitals, there are hospitals where the average hospitalization cost is very high, but there are also these are hospitals that are problematic, and this can be seen by the number of deaths, by the average hospitalization time, the services they offer. And we have hospitals, on the other hand, that are underfunded, and this is on the data we have and we know, and on the basis of data we have per patient and DRG, and we know that these hospitals are doing very well. These hospitals need to be strengthened, and then we need to check the other hospitals in order to identify why the services offered are not the expected ones. In the process of DRG, we have improved the pathway of the patient, when and where they will enter, how each service will be cost, and of course every service need to be reimbursed on the basis of the real image of a patient and not on an image that we want to have in our minds. And this is our main concern. This is something that we are trying to do by increasing the quality of data we get from hospitals, by the audits we perform through the use of specific platforms, but also through the use of the available data, so that we can have the best possible data, which in turn will lead to better reimbursement. And you can be sure that the better reimbursement of hospitals will lead to better services. Okay, I have congratulated you on your work, actually. It is a continuation and a far better addition to my work. And I would like to ask Mr. Katsarkas about these reports. These reports are received by the manager of the hospital, and with regard to the cost, if I'm not mistaken, you have included everything with regard to the pathway of the patient. I would like to tell you that in the United States, they have proceeded to the bundle payments, certain DRGs that actually define these payments. And of course, the salary cost that you have predicted pertains to the existing salaries, to the current salaries of the public health system. But maybe we should give some incentives to the people, and maybe we have time. At the end, you can say a few words about that.
Let's move on to Mr. Anastasios Katsarkas. He's director of a clinic in Thessaloniki. It's a traditional, a very good clinic, Mr. Katsarkas. As we used to say, I knew your father years ago and his efforts. And you, Mr. Katsarkas, representing not just the clinic, but also the private sector in Thessaloniki, what are the activities that you develop in the functions, the clinical functions, nursing functions that you coordinate, but also the prevention and prices, so that all these things will have value for your patients? Good morning. Thank you as well for this invitation. I should like to say that Agios Lukas is not the typical example of a private vendor of healthcare services, because we're slightly non-profit. We work on the fringe of the private sector, which allows us traditionally to focus on the patient and what we are now calling patient experience. All our actions always take into consideration cost. But since our operation is non-profit, it's easier for us to prioritize the results, which is value for the patient, rather than the end result, which is profit for the business. One example I can give for what you said is a radiotherapy department which we built recently, and we equipped with the state-of-the-art in the world, and we selected to use a specific system that will monitor the patient's breathing and the performance of the treatment on the patient, which is not reimbursed specifically. It does have an increased cost in the treatment, but it increases efficiently in an impressive way. This is the mentality we have in order to be able to attribute value to healthcare for the patient. Now, listening to Mr. Nikas earlier, I wanted to say that technology is something that we always try to incorporate in our operations. And the only thing we have as a limiting factor is the cost that is added to the patient's treatment, because there is patient out-of-pocket participation in treatment in the private sector. So in the implementation of the DRGs is something that we are looking forward to in order to better today's environment. We're not very optimistic regarding the DRGs, not only because we think of it as a perfect system, but because the current situation is very, very dire. The situation with the CAN is very dire. There's a lot of cost, and there's a lot of things. Do you have a contract with the EOP? Yes. And the CAN is not enough? It is not. Well, let's hope that the DRG will be enough. This is exactly what I said, which is why I have our good colleague here. Now, the other thing is the logic on the basis of the clinic. Is it on the basis of the specialty with you? And to put these things forward, are there clinical reports that reach your hands? There are benchmarks, there are metrics, there are everything, there's a lot of things. And we call it like this because this is what we call them in private hospitals. I mean, Agios Lukas and other big hospitals is exactly like all other hospitals in all over the world. Have you been certified? Yes, we have received certification on the basis of various standards and for our microbiology laboratory and, of course, the entire operation of the clinic. I'm saying this because it is very important for all these tools to receive a certification, make it practice, and to have them here for the future. Mr. Giorgos Chalkiadakis, he is, of course, as we all know, with the Hospital of Heraklion. It's one of the biggest 7 university regional hospitals and definitely the largest, the biggest in Crete. I would like you to tell us what your actions are regarding the medical, nursing, medical hospital value, but also how you measure the results of this value per clinic or per sector. And the second thing I wanted to raise for your patients is what is your collaboration with Crete? Because I know that there are a lot of referrals. So medical, hospital value, results and collaborations. Right, well, me and my partner, Mr. Niadakis, took over managing the hospital in January of 2020. Now, we were fortunate enough, I had served with that hospital since 1990. So I knew people, I knew things, which helped me particularly to be able, in this difficult era, because when we took over the next month, the pandemic broke out and we had a very difficult period. Of course, we said that it's forewarned is forearmed, and as soon as we had the first case, the first incident in China, that was never made public. We started with the infectious disease committee preparing the stuff. So in February or March, when we had the first case in Thessaloniki, in Greece, we already had done some preparatory work. And so when the first cases started in Crete, our staff was already well prepared, which was very good for us. Now, the collaboration of the medical and nursing staff at our hospital is very good. All acts are evaluated, both the surgical acts, but also medical acts, all acts. There is logging and recording of all the problems. The nursing service has their protocols for various things. The medical service is trying, but I'm not yet satisfied regarding the assessment and evaluation of the medical acts. There is an ISO for most of the clinics and the labs, and I think that the university hospital is one of the best hospitals in Greece. Not just because I'm the governor there, but on the basis of data, on the basis of facts, on the basis of results. We're the first hospital where the DRGs started from, and we have a very good collaboration with Mr. Messaropoulos. There are, in fact, some problems until the full implementation of the DRGs, because we'll need to see how to implement it technically. I mean, doctors are not very eager or very willing to do that because they feel it's additional red tape imposed on them, and some say that it's not our business. Well, the discharge papers are your job, so you need to do this, otherwise there's going to be a problem. There is another malfunction in some clinics. There are some clinics that do their duties 100%. Some others are at 60% regarding the DRGs. And there we will see in which way we'll do that, despite the fact that we have talked with the IT people how we can link the discharge papers with the DRGs, unless they have filled in the DRG, not to be able to discharge the patient. And so I think we will be able to resolve these problems. I believe that the University Hospital of Heraklion is offering high-level services, and that there are services unique to Crete. I mean, there are no... this is the only place we have thoracic surgery in Crete. Elsewhere, I'm talking about state hospitals, of course. There are departments such as the PET scan, which is the only one in Crete. We have the vascular cerebral stroke service that offers a lot of service and actually saves lives. It started a year and a half ago with very good results, if I may say so. And one way or another, there are some clinics that are of the very high level, which makes us proud and happy. We try to help. We try to improve our medical technical equipment. We have a new MRI, a new CT scanner, a new angiogram scanner, and we perform innovative and pioneering surgeries with the stents, new stents, and various difficult cases are treated in the intralumen axis, which raises the level of services offered. As a program, we have said that we will be installing robots to assist in robotic surgery, because there are already doctors experienced in robotic surgery from abroad, which I believe will further improve the provision of services. Right, excellent, but I will insist both on what I said during my prologue and what Mr. Messaropoulos said. Clinical reports. But it says 17 minutes there, so I have 3 minutes, don't I? Right, okay, thank you. Now, clinical reports. You receive clinical reports, you receive results. I mean, the Onassis thoracic surgery that Mr. Nikas says they had a mortality. That checks this 1.5% where it came from. Well, according to some clinics, when I was director of the surgical clinic, once a month we had a meeting. It was on mortality. There are some clinics that do have this meeting once a month. There are the internist ones and the GP. There is no information towards the central administration. It's something that, following discussions that I had with the director of the medical service, we said that per sector we will need to have at least once a month such a meeting in order to have official data. The number of deaths, we do have the number of deaths. It's the cause of death that we do not have in an organized way, and this is what we're doing. I'm very happy for this conference to be another opportunity for you to make it happen. Now, I would like to ask you, instead of your alternate, do you feel limited from the financial capabilities given to you to implement these tools? Or isn't financial capability, it doesn't enter into these tools? Well, of course it does. It's all about the money, is what our ancestors said. So unless you have the money here, and we have a new PET scanner here as of last year, it's very, very expensive for us. The contrasting agent, the radio contrasting agent in Greece, and the rest Greece, costs 116 or 160 euros. In Crete, it costs 570 because it is flown in a special plane. The cost of the flight is 4,700 euros. Well, of course, you realize that it's another reason. Right, I said it's 9 or 10 months ago, the vascular cerebral stroke unit was introduced, and the cost per action is around 20 to 25,000 euros. The stents, something that becomes a routine. There are more numerous and more complex or complicated, resulting in the cost of the grafts to double. The TAVIs, the aortic valves, the cost of the TAVI alone is around 22 or 23,000 euros. So cost does enter into it and it affects it? Yes. For us, for the hospital, yes. I don't know whether some of the other gentlemen would like to say something for a minute and a half. Yes, Mr. Nikas, 30 seconds each. Right, I would like to say that, well, we have procurement as an issue. I mean, okay, we can't look very far. Let's use the useful practice of measurement, as we saw earlier, and to allow the public sector to buy results. We don't need gadgets. We need programs, and to demand the vendors to undertake their responsibilities in a measurable way. And if we can't measure them in the hospital, to support this measurement, because it makes us better. And since we have the predictability on behalf of the public sector, we reduce the cost and increase funding. Mr. Nikas, another 30 seconds. 30 seconds to say three things. DRGs are very important, that finally, ultimately, after all these years, we will have a new system. And in order to have procurements on the basis of value, we will definitely need for the measurements, and something you mentioned earlier, asking Mr. Halkiadakis, in the clinical results, that financially to see what happens at the hospitals, and have such a culture and such a strategy in procurements on the basis of value, not just price. Training of the staff also for procurements, for EKAPY, on value-based healthcare, and of course some centers that can do such things all over the place. Otherwise we cannot actually do that elsewhere. If we have scattered and dispersed cases, we can't do anything. So I take this pass from you and say that the country may have 125 public hospitals and another equal number, even more, of private clinics, but the big ones, on the Pareto's theorem, 80% is in the large university regional hospitals and in the 10 big private hospitals. This is where we should be starting all this story, and I think that we're giving a very good pass for the next table, and primarily for the 215 table that will have the Deputy Minister here as well, that will be talking about the hospitals. I should like to thank you all, and thank you for being with us.